Colorectal cancer is a cancer that starts in the colon or the rectum. These cancers can also be named colon cancer or rectal cancer, depending on where they start. Colon cancer and rectal cancer are often grouped together because they have many features in common. Frequency of colorectal cancer varies among population. There is low incidence among Asian. In the United States, colorectal cancer is the third deadliest of all cancer. There is also higher prevalence in the involvement of the cecum, ascending colon and sigmoid. Greater than 75 to 95% of colorectal cancer occurs in people with little or no genetic risk. Risk factors include older age, male sex, high intake of fat, sugar, alcohol, red meat, processed meats, obesity, smoking, and a lack of physical exercise. Environmental factors related to colorectal cancer include beer and ale consumption, low dietary intake of selenium, presence of certain colonic bacteria and some substances from char-boiled meat and fish. There are also factors that are believed to have protective properties against the development of colorectal cancer, such as high fiber consumption, physically active or with low body mass index, use of aspirin and calcium are said to have protective effect. Highly possible protection from colorectal cancer is derived from intake of yellow and green vegetables, and vitamin A-rich food among others. In the biology of colorectal cancer, genetic changes are proto-oncogenes, loss or tumor suppressor gene activity. Those with a family history and 2 or more first-degree relatives, such as a parent or sibling, have a 2 to 3-fold greater risk of disease, and this group accounts for about 20% of all cases. A number of genetic syndromes are also associated with higher rates of colorectal cancer. The most common of these is hereditary nonpolyposis colorectal cancer, HNPCC, or Lynch syndrome, which is present in about 3% of people with colorectal cancer. Other syndromes that are strongly associated with colorectal cancer include Gardner syndrome and familial adenomatous polyposis. Colorectal cancer patients have abnormalities in genes involved in DNA mismatch repair. Genomic instability creates permissive state cells, which acquires enough mutations to be transformed to a cancer cell. Several of these forms include chromosome instability. In the pathogenesis of colorectal cancer, the primary malignant neoplasm leads to vascularization, then invasion of adjacent tissue. Here embolization of cancer cell, and this is transported to other organs. In this new location, tumor cell adhere and colonize. Extravasation of cells and nutrients and cells occurs until the microenvironment is established. From here a secondary tumor or metastasis is formed. Hereditary nonpolyposis colorectal cancer, HNPCC, has the following clinical features. Mean age at diagnosis is 45 years. There is tendency toward proximal sites of colon tumors and multiple primary malignancies. Higher incidence of mucinous carcinomas and poorly differentiated cancers. Criteria for diagnosis is at least 3 relatives with colorectal cancer and 1 must be first-degree relative of the other 2. Colorectal cancer involving at least 2 generations. 1 or more colorectal cancer cases before the age of 50 years old. Hereditary nonpolyposis colorectal cancer is subdivided into 2 syndromes. Lynch syndrome 1, which is a heritable cancer limited to the colon and rectum. Lynch syndrome 2 involves families whose members are prone to cancer of the female genital tract and other sites. Risk factors of colorectal cancer notes that malignancy rate is higher in large adenomas, adenomas with villus architecture, and adenomas with cytologic nuclear atypia or dysplasia. Cholecystectomy could lead to increased delivery of secondary bile acids to proximal bowel and right colon, which increases risk to development of adenocarcinoma. Colorectal cancer has a gross feature of large bulky tumors in the proximal colon. These cancerous new growth outgrow their blood supply, leading to necrosis. In the distal colon, the tumor produces annular constriction or napkin ring appearance. Histologically, most of colorectal cancer are adenocarcinoma. Mucinous or colloid carcinomas are most frequent in patients with genetic predisposition to such diseases, especially those who develop carcinomas at an early age. Colorectal cancer has a mean doubling time of about 620 days. Lymphatic and hematogenous spread are unusual before penetration of the muscularies. Rectal cancers spread to local structures. The lower third of rectum spread via superior hemorrhoid vein and portal system. Rectal tumors in the upper and middle third drain into the portal system. Batson's vertebral venous plexus may allow lumbar and thoracic vertebral metastasis. Staging is typically made according to the TNM staging system from the WHO organization, the EC and the AJCC. The Asler-Collar classification, 1954, and the Dukes classification, 1932, are now less used. T stands for tumor stage and ranges from 0, no evidence of primary tumor, to T4 when the tumor penetrates the surface of the peritoneum or directly invades other organs or structures. The end stage reflects the number of metastatic lymph nodes and ranges from 0, no lymph node metastasis, to 2, 4 or more lymph node metastasis, and the M stage gives information about distant metastasis. M0 stands for no distant metastasis, and M1 for the presence of distant metastasis. A clinical classification, CT&M, is done at diagnosis and is based on MRI and CT, and a pathological TNM, PT&M, classification is performed after surgery. Colorectal cancer have the following clinical features: bowel obstruction or perforation has been linked to poor prognosis and may not be candidates for curative surgery. Bowel obstruction or perforation has been linked with poor prognosis and may not be candidates for curative surgery. Rectal bleeding as a presenting symptom may be associated with improved prognosis. Tumor recurrence is higher and the estimated mean time to recurrence shorter, in Dukes B and C who have high preoperative CEA levels. Most important determinant of survival time for those with liver metastasis is the extent of hepatic involvement by tumor. Clinical presentation will differ on the location of the tumor. Right colon cancer presents with constitutional symptoms due to chronic anemia, feces are colored mahogany or dark reddish. Patient presents with vague abdominal pain or palpable mass. In patients with left colon cancer, they complain of colicky abdominal pain after meals, change in bowel habits and bloody stools with distal lesions. Colorectal cancer diagnosis is performed by sampling of areas of the colon suspicious for possible tumor development, typically during colonoscopy or sigmoidoscopy, depending on the location of the lesion. It is confirmed by microscopical examination of a tissue sample. As more than 80% of colorectal cancers arise from adenomatous polyps, screening for this cancer is effective for both early detection and for prevention. Diagnosis of cases of colorectal cancer through screening tends to occur 2 to 3 years before diagnosis of cases with symptoms. Any polyps that are detected can be removed, usually by colonoscopy or sigmoidoscopy, and thus prevent them from turning into cancer. Screening has the potential to reduce colorectal cancer deaths by 60%. The 3 main screening tests are colonoscopy, fecal occult blood testing, and flexible sigmoidoscopy. The treatment of colorectal cancer can be aimed at cure or palliation. When colorectal cancer is caught early, surgery can be curative. However, when it is detected at later stages, for which metastases are present, this is less likely and treatment is often directed at palliation, to relieve symptoms caused by the tumor and keep the person as comfortable as possible. For surgery, segmental resection results is equivalent to supraradical colonic and lane resection. For lesions of rectosigmoid and upper rectum, low anterior resection. Abdominoperineal resection is indicated for large bulky tumors deep within the pelvis, and extensive local spread of rectal cancer. Surgery is still indicated for advanced tumors for palliation of symptoms. Resection of cancer should not be limited or denied on the basis of age. For adjuvant chemotherapy, treatment is most effective when tumor burden is minimal and cell kinetics are optimal. 5-FU plus levamisole significantly reduced recurrence rate and death. 5-FU plus lecaverin should be considered the new standard for adjuvant treatment. For adjuvant chemotherapy, results are disappointing for stage 4 disease. Selective infusion of chemotherapeutic agents into hepatic arterial system may be employed to treat hepatic metastasis. In Europe, the 5-year survival rate for colorectal cancer is less than 60%. In the developed world, about a third of people who get the disease die from it. Depth of transmural tumor penetration and the extent of regional lymph node spread are the most important determinants. Exophytic or polypoid tumors have a better prognosis than those with ulcerating or infiltrating tumors. Mucinous carcinomas are more aggressive. Signet ring carcinomas present at an advanced stage and are highly invasive.